Good evening, everyone. Today we'll discuss about glucocorticoid-induced osteoporosis. In the last class on Saturday, we discussed about osteoporosis in general because glucocorticoid-induced osteoporosis is an important topic, and already osteoporosis was a longer topic, so we decided to have a separate class for this. This will be a very small class because we'll be discussing this focus topic only, maybe half an hour or so. So we will begin with this. So as we know, glucocorticoid-induced osteoporosis is actually the most common cause of secondary osteoporosis. So primary osteoporosis is age-related, as we discussed last time, postmenopausal or older age are the risk factor for the primary osteoporosis. Secondary osteoporosis, most common is drug-induced, and the most common drug which is uh, implicated is steroids, and predominantly affects regions with abundant cancellous bone. As we discussed last time in lumbar spine and proximal femur, because the amount of trabecular bone is much higher, and we know that trabecular bone is the one which is more prone for osteoporotic changes. That is why that secondary osteoporosis, because of steroid, also will be affecting lumbar spine and proximal femur more commonly. And there are 2 points which goes in favor of glucocorticoid induced osteoporosis. That includes rapidity of bone loss at the introduction of therapy and discrepancy between bone marrow density, BMD, and risk of fractures, BMD and risk of fracture. So, 2 points are there. First thing is, as soon as you start steroid therapy, in the first few months of therapy, the risk is maximum. It rapidly increases. Second thing is, although there is loss in BMD, but apart from BMD loss, there are some additional factors because of which there is increase in risk of fracture. So let's see. When you start steroid therapy for any patient, there are different phases. If you see in this figure, just see this is the 0 point where we are starting treatment, and then this is how the course follows. So if you see this first 3 to 6 months, in the first 3 to 6 months of beginning of steroid therapy, there is osteocyte apoptosis leading to deterioration of bone quality, and there is fast bone loss due to a relative increase in resorption without corresponding formation in pre-existing BMU. So what does that mean? You remember one thing. Last time we were discussing that in adults, bone undergo a process of remodeling where this osteoclast mediated bone resorption as well as osteoblast mediated bone formation is going on simultaneously. So what happens when you provide steroid? In the early phase, there is increase in the lifespan of osteoclasts. Once osteoclasts are long living cells, then what happens? They will form deeper lacunas, deeper pits in the trabecular bone. That is the reason why in the earlier time or the very beginning phase of time after the steroid therapy, the bone loss is maximum. So as we see in this figure, in case of earliest 3 to 6 months, there is more bone resorption because of increase in lifespan of osteoclast, and also there is osteocyte apoptosis leading to deterioration of bone quality because these cells they go uncontrolled and they go unnatural cell death. In the later phase, after first 3 to 6 months, which is mentioned here as C, if you see there is gradual accumulation of unrepaired defects due to suppressed remodeling. And in the last phase, the D and E as mentioned here, if you see, there is a fast repair of defects by resurgent remodeling, and there is restoration of osteocyte network leading to improved bone quality. So this happens when once therapy is stopped. As soon as therapy is stopped, like here, after that it takes at least 3 to 6 months to recover the strength of the bone. So what happens? More than 10% of patients who receive long-term therapy with steroids, they are diagnosed with the fracture, and 30 to 40% will have radiographic evidence of vertebral fracture. That means the number of patients who are symptomatic for glucocorticoid-induced osteoporosis, approximately 4 times patients are there who will not be having any symptoms, and this is the reason why you should actively look for presence of steroid-induced osteoporosis in all patients, irrespective of any presenting symptoms. The highest rate of bone loss occurs within the first 3 to 6 months of therapy, and a slower decline continues with persistent use. Moving on, BMD loss is biphasic when therapy is given. So for the first 3 to 6 months, there is a rapid loss, 6 to 12% loss within the first year, and more slowly, approximately 3% loss yearly thereafter will be occurring. If you remember from the last class, I was telling that there is a peak bone mass attainment at 30 years of age, which stays there for 10 years, and there is then 0.3 to 0.5% per year BMD loss. Now realize, when you're starting this therapy, this loss is 6 to 12%. So it is very, very much higher compared to what the background BMD loss rate is. And however, the risk of fracture escalates as much as 75% within the first 3 months after the therapy initiation, typically before there is substantial decline in BMD. That means the risk of fracture and decline in BMD have poor correlation. That is because apart from decline in BMD, there are other factors because of steroid therapy which are increasing the risk of fracture. Uh, Increase in the risk of fracture has been reported with the use of inhaled steroids also, as well as with alternate day and intermittent oral regimens as small as 2.5 to 7.5 mg of steroid per day. That means no dose of steroid is safe, no form of steroid is safe, as oral as well as inhaled, as well as low doses, as well as alternate day regimen, all have been implicated with the steroid-induced osteoporosis. Now, there is no cutoff in literature that if you give that much steroid, the risk is will not be there, or if you provide that much steroid, the risk will be that much. That kind of thing is not there. Although a common gesture is if you provide high dose of steroid, the risk is higher. How much, that factor is not known. So coming to risk factor for glucocorticoid-induced osteoporosis. So these are the factors. This table has been taken from one of the articles. Risk factors include advanced age, low body mass index, underlying disease, including your RA patient, rheumatica patient, IBD patient, COPD patient, transplantation patients. Then prevalent factors like smoking, excessive alcohol consumption, frequent falls, family history of hip fracture. Then there are some polymorphism in glucocorticoid receptor. Obviously, some polymorphism which are associated with the more activity of these pathways. Then there is association with increased 11 beta hydroxysteroid dehydrogenase type 1 expression, and high steroid doses and long duration, and low bone mineral density. Now you see this table. This table is exactly showing most of the factors that we discussed in the last class, which are already a determinant of the bone mineral density. So presence of other factors along with steroid use will increase the risk for steroid-induced osteoporosis. This is how we can remember it. Now, if you see pathophysiology of steroid-induced osteoporosis and the effect on the bone, there are effect on osteoblast, osteoclast, and osteocytes. As we know, these three are the principal cells which are present in the bone. There are some short-term effect, long-term effect, and net effect. So if we see in osteoblast, there is upregulation of PPR gamma 2, KLF15, and other genes that are involved in differentiation of pluripotent stem cell to adipocytes. It means more fat cells will be forming. Then there is Wnt beta pathway, and there is increased sclerostin production. Then there is dose-dependent osteoblast autophagy and increase in rank ligand expression and decrease in osteoprotectin. This is short-term effect. In long term, there is decreased osteoblast genesis and increased apoptosis. In the net effect, there will be reduced number of osteoblasts and increase in fat cells. So once osteoblasts are reduced, now automatically we'll know that because there are less osteoblasts, there will be less bone formation as osteoblasts are involved in the bone formation. Coming to osteoclasts are the cells involved in resorption of the bone. So once there is steroid therapy, as I already was discussing, that what happens once you provide steroid will increase the lifespan of these osteoclasts in the beginning. If there is increase in the lifespan osteoclasts, they will remain longer there on that BMU unit, and they will form the deeper pits. Deeper pits means more bone resorption and more bone loss. And long term although osteoclast effects is less clear, we don't know. In case of osteoclast, glucocorticoid can disrupt the osteoclast cytoskeleton, leading to depressed osteoclast activity despite promoting their lifespan. But as we can see, there is so much effect on osteoclast in the short term that overall there is increase in osteoclast activity. Coming to osteocytes, as we know, osteocytes are formed from osteoblasts and they are involved in the mechanosensation of the bone and signaling of the bone loading, and then perception of bone loading and involvement in bone formation. In short term, osteocytes they will undergo apoptosis because of steroids. There is a modification of elastic modulus surrounding osteocyte leading to altered bone mechanical properties, and there is increased sclerostin and DKK1. Now remember, we discussed last time, this sclerostin and DKK1, they are inhibitors of the bone forming pathways. So overall, what will happen? There will be decrease in osteocyte and there will be altered bone biomechanics. So all these effects will actually lead to poor bone quality and increased risk of fracture. Now remember, we are talking about the risk of osteoporosis and we are talking about the risk of fracture. So risk of fracture can increase either because of risk of only bone loss, or there are other pathways through which steroid is detrimental. Now see how. Bone we discussed already, like it is altering function of osteocytes, osteoblasts, and osteoclasts. Ultimately, what it is leading to? It is leading to reduced bone formation, poor quality of bone, reduced bone mass, and this all will contribute to increased risk of fracture. Now, if you see, apart from bone, there are effects of steroid on neuroendocrine system, calcium metabolism, and muscles. In case of neuroendocrine system, we know if we provide steroid, there is suppression, there is less of growth hormone, less of IGF-1, reduced sex steroids, and all this will also lead to reduced bone formation. As far as calcium metabolism is concerned, steroid they reduces intestinal absorption of calcium and they increase in excretion. That will lead to negative calcium balance, again attributing towards the poor bone quality and bone mass. And as far as muscles are concerned, when you provide steroid for long term, then this proteolysis of myofibrils, decreased fibrils, myopathy can occur, muscle weakness can occur, and it can it can lead to increased risk of falls. So apart from reduced BMD, reduced bone quality, there are other pathways and factors through which there is increased risk of fracture with steroid use. So this is about pathogenesis of how steroid is working in contributing towards the poor bone quality and increased osteoporosis risk. Now, how to assess the risk and how to stratify it. So this table is from the recent most latest guideline that came in 2017 for glucocorticoid-induced osteoporosis, and this actually divides your patient into three categories: high fracture risk, moderate fracture risk, low fracture risk. And we have to also see what is the age of patient, if it is more than 40 years of age and less than 40 years of age. So this table, I have simplified it for you further. Now see this table. First, you see the patient who are more than 40 years of age, because we know as the age increases, the risk of fracture increases. So that risk stratification has divided patient into two different groups. In case of 40 years of more than 40 years of age patient, if you see, there is something, there is BMD, then there is a risk of Frax score risk of major osteoporotic fracture and hip fracture. So suppose somebody is having BMD less than, this is T score actually, less than minus 2.5, obviously he has osteoporosis by definition, or there is more than 20% risk of major osteoporotic fracture, or there is more than 3% risk of hip fracture in 10 years. So if any of this is present, automatically we will keep our patient as high fracture risk. Then moderate, they have not given BMD cutoff for this thing, but 10 to 20% of this major osteoporotic risk and 1 to 3% of hip fracture risk will come into moderate fracture risk, and less than 10% here and less than 1% here can be taken as low fracture risk. So this cutoff is actually taken into more than 40 years of age. Suppose if any patient is having any kind of osteoporotic fracture, then if fracture is there, then automatically patient goes into high fracture risk irrespective of other factors. And if suppose patient is more than 50 years of age and postmenopausal, because we know this is the risk factor for osteoporosis, these patients, these females will also be taken as high fracture rates. So presence of T score less than minus 2.5, presence of major osteoporotic fracture risk, FRAX score more than 20%, hip score more than 3%, presence of any fracture, osteoporotic fracture, and postmenopausal females. If any of this condition is present, your patient automatically goes to high fracture risk. And then score of FRAX, osteoporotic fracture and hip fracture, you can divide your patient into moderate risk or low fracture risk. Now coming to 40 years, less than 40 years of age. Now, less than 40 years of age, patients are actually less prone to fracture. That's why there is increased threshold for that thing. So if patient is having any kind of prior osteoporotic fracture, patient automatically enters into the high fracture risk. As we can see here, this condition is same in both the groups. As far as BMD is concerned, there is no low fracture risk. This thing is there, but if there is presence of BMD, T score less than -3 at hip or spine, or there is rapid bone loss, like more than 10% of BMD loss in 1 year, with glucocorticoid therapy at least 7.5 mg per day for more than 6 months, this can be taken into the moderate risk. Generally, nobody repeats this BMD scan at 1 year, but this is how they have mentioned it. So if any of this condition, if this condition or this condition is present, then you can take your patient into moderate fracture risk. This is how you divide your patient into, this is how you stratify your patient into low fracture risk, moderate fracture risk, and high fracture risk. And depending on, we will see how we are going to treat them. So this flow diagram is from that guideline only. So let's say you are seeing children and adults who are taking steroid, you want to see them for presence of steroid-induced osteoporosis. So what they're telling that you have to clinically reassess this patient every 12 months, it means 1 year. So generally what happens in case of children, remember in case of children, we are using G score, not T score. In case of children, there is no additional reassessment other than clinical fracture risk reassessment every 12 months. So that you do, no imaging. Now come to adults which are less than 40 years of age. In these patients, if there is history of osteoporotic fracture or Z score is less than -3 at hip or spine, or there is a rapid bone loss like more than 10% of BMD loss at hip or spine, very high dose glucocorticoids, or if there is presence of other osteoporosis risk factors, as we discussed in last class, if these are there, then BMD testing has to be done every 2 to 3 years, whether treated or untreated. If there is none of these factors there, then no BMD testing is required. Coming to adults more than 40 years of age, if suppose there is a patient who has never been treated with osteoporosis medication, then FRAX with beam testing is required every 1 to 3 years. You can do it earlier also if patient was on high dose of steroid or there is a history of osteoporotic fracture. Suppose patient is getting treatment, then if during osteoporosis treatment patient is on very high dose of glucocorticoids or there is a history of fracture at least 18 months after beginning of osteoporosis treatment, poor medication adherence or absorption, other OP factors are there, then you have to go for testing every 2 to 3 years. If it is not there, then no testing is required. And if somebody has completed treatment for osteoporosis, then beam testing every 2 to 3 years. So idea is that if patients are having any major risk factor for osteoporosis, then you should test every 2 to 3 years. Now, this is the treatment. So this was how you are going to test them. This is the treatment, how you treat them. So treatment, as already we discussed, that we have to stratify our patient low risk of fracture, moderate risk of fracture, high risk of fracture, and then age according to age. So if you see, it is more or less same only. So how we are going to treat them? We have to see non-pharmacological methods, including exercise and then diet, and then we have to tell everybody to take adequate calcium and vitamin D, irrespective of their risk category. Everybody will be receiving it, although I have not mentioned here, but take it like calcium and vitamin D will be given to everybody irrespective of their risk category. So whenever you write steroid any dose to your patient, you always make it a reflex that whenever you write steroid, let it be 2.5 mg of prednisolone, let it be 5 mg, 50 mg. The next drug that you are writing after steroid should be calcium. So this is how I remember it. This is how Sanket remembers it. This is how we remember it as rheumatologists. Whenever we write steroid, the next drug that we will write calcium so that it is not missed. So, in case of low risk category, treatment generally with anti-resorptive therapy is not required. Only calcium, vitamin D, lifestyle modification is required. In case of moderate to high risk of fracture, they have told that you can give any other drugs, but generally this is the sequence how you follow it. Generally, oral bisphosphonates are preferred over IV. Then you can either go with teriparatide, denosumab, and raloxifene. So remember this that guidelines are there to guide you. They are not the hard and fast written rule. If suppose you want to give your patient teriparatide, you can give that also. If you want to give your patient denosumab, you can give that also. You want to give your patient IV bisphosphonate, you can give that also. Generally, these like one drug is preferred over other is on the basis of many factors. Most commonly, it is based on the data availability. So we know that these bisphosphonates are there in the market for longer time. That's why they have given the preference. Otherwise, it's up to you what you want to give. So all adults taking prednisolone at a dose of more than 2.5 mg over 3 months, irrespective of their risk category, everybody should be getting calcium and vitamin in adequate doses up to 800 to 1000 mg per day calcium and vitamin D 600 to 800 international unit per day. It has to be given to everybody. Now, this was about adults. So, in if we see pediatric, now what can happen? Suppose if a patient is there, a child is there, 8-year-old child is there, and 8-year-old child is having a fracture, and you think that it is an osteoporotic fracture. Suppose there is no history of any high impact trauma, patient is on steroid therapy, and then patient is having fracture. In such condition, how to treat? So this is from one of the pediatric guidelines. Now focus on this green thingy. What they are showing that treatment with bisphosphonates should be administered to those pediatric patients with osteoporosis. That means G score less than -2 plus presence of pathological fracture, or if there is any vertebral fracture regardless of G score, then these patients are candidate for your bisphosphonate therapy. Then other thing is bisphosphonate can be considered for patient without osteoporosis but a low BMD in early puberty up to 10 or 2 stage when active risk factors are there, and patient with G score with with active when active risk factor is there along with BMD of less than 2.5 G score, or when patient no longer present active receptor, patient with G score less than -3. So what they want to say basically, they want to say that anybody, any child who's having any kind of vertebral fracture, irrespective of BMD, you start treatment with bisphosphonate. That is the one indication. Second indication is if there is active risk factor and there is presence of BMD less than 2.5, then you start treatment. If there is no active risk factor, then you start treatment at G score less than -3. So these are three indications that you should know when you will start your patient on bisphosphonate. Apart from that, other thing, vitamin D supplementation, calcium, that everything should be like a reflex you have to give for everybody. As far as one other recommendation is concerned, just focus on this point number 50 and 51. These are level of grade A recommendations. So for children and adolescents receiving steroid chronically and presenting with low BMD mass, that is G score less than -2 plus one fracture, osteoporotic fracture, it is recommended to use bisphosphonate associated with calcium and vitamin D. Then lateral spine X-rays or BMD checks with DEXA are not recommended on a routine basis for those children and adolescents being treated with inhaled corticoids at doses less than 800 microgram per day unless they present other risk factor. So because most of the many children will be receiving treatment for asthma, they will be on inhaled therapy. So unless there is dose is not very high, like not more than 800 micrograms per day, that is, if it's not they're not receiving more than this, then you can avoid doing these images. Otherwise, imaging can be done. So these two recommendation, and then treatment of these 3 points, like presence of either vertebral fracture or presence of G score less than -2 plus any pathological fracture, or a risk factor with the plus a risk factor along with the reduced BMD less than -2.5, or if BMD is less than -3. In these four conditions, you can think about treating these patients. So these are the recommendations as well as far as pediatric population is concerned. Apart from this, there is no other any guidelines for the pediatric age group. Follow up in GIOP. How will you follow up once you start treatment for this low and moderate and high risk of your patients? Then how will you follow up in this patient? So in case of adults who are more than 40 years of age and were on ongoing treatment of steroid, if they had a fracture that occurred more than 18 months after beginning of treatment with an oral bisphosphonate, or they are having a significant beam decline that is taken as more than 10% loss per year, then you can consider to treat with another class of medication like teriparatide or denosumab, or you can take an IV bisphosphonate. So this is a conditional recommendation because there is no much data about this. But if suppose bisphosphonate is not working, then you can either change the agent to IV or you can go with the another class of agent. Then one other thing is for adult patients who have completed 5 years of oral bisphosphonate treatment, who are continuing steroid therapy and are assessed to be at moderate to high risk of fracture, continuation of active treatment for osteoporosis is recommended. So what do they want to say? When we were discussing in the beginning, you have to assess every 1 to 3 years, 1 to 3 years, 1 to 3 years. If you assess your patient after starting therapy, that their risk has not reduced, like their risk of fracture is still they're falling in moderate to high category, then you have to continue your bisphosphonate therapy. That is the message from this. Uh, they suggested treatment for this will include continuing the oral bisphosphonate for 7 to 10 years, switching to an IV bisphosphonate if absorption of adherence is a problem, treatment with another class of OP medication. So now the overall message is if your drug is failed in terms of having a fracture or reduction in BMD, or if your drug is failed in reducing the risk category of your patient, in both the cases, you can go with another class of OP medication. That is the message from this follow-up guideline. Then, if suppose somebody is there who's like steroid is stopped, discontinued because of the reason, because suppose condition is okay now, it doesn't require steroid, something is like that, then what to do? For adults more than 40 years of age who are treated with osteoporotic medication in addition to calcium and vitamin D, and they are discontinuing their steroid treatment, discontinuation of the medication is recommended if if only their fracture risk at the time of glucocorticoid discontinuation is assessed to be low. What does that mean? That means even if you stop steroids, if your patient in moderate to high risk of category, then the treatment is warranted. Only if they were falling in the category of low risk, then you can think about stopping their treatment for osteoporosis. Otherwise, the OP treatment course should be completed or continued until the fracture risk is assessed to be low. This is what I was telling. And continuation of OP treatment in the setting of high risk is a strong recommendation, and others are conditional recommendation. So what does that mean? That means even if your steroid therapy is stopped, even suppose after 2 3 years your therapy is stopped, but your patient is still having a high risk of fracture, then you continue treatment as you continue for your other patient of osteoporosis. So this is what they want to say from this. Thank you. This is the only thing in glucocorticoid-induced osteoporosis. If anybody has any question, then questions are welcome.